link. Try that one. Okay. Click where you can find some line or something. If not the HTT thing. Benita, is there any other means? You remember the last time you were able to send me a link to my WhatsApp?
What is the name of the person, please?
That is Judith. Judith
But her
Cater.
email is beyond.
Her email is Beyond Burn International. Who email you about it? Beyondburn at international@gmail.com.
Beyond Burns International. Should I put it in the
Yeah, put
chat?
it on our chat group and let's see if she can use that to join. Okay, I think she said she's able to join now.
She's able to
We
join?
don't see you. Women internet is stronger. Women internet is stronger. I'm sure it's strong.
Your microphone is mute, Judith. Your microphone is mute.
Okay, bye.
Can you see me?
Yes. Now we see you very well.
Ah,
Okay, good. We're all here. We're all here. This is great. So everybody can unmute, mute. I would really like to ask you to help in capturing photos of the event when you're not speaking or you're not stressed. That would be great. Straightforward, succinct. So hopefully we'll have more time in the discussion to elaborate a little bit more from all of us. Any questions before because we have, 9 minutes. Any questions? Some clarifications needed?
For the pictures, the screenshots, Binta, what do you use? Like snipping tool or is it embedded in the Zoom?
I don't know if anybody has a better way. I use the snipping tool, but I don't find it very
Okay.
effective. I don't find it very effective. So I don't know, Dennis, you're the IT whiz.
What do you mean?
To take screenshots of what do you use? Do you use a special?
No, I use the snipping tool.
Okay.
I just use my phone to put it on our page.
To take a
okay.
picture.
Okay.
Okay.
And Judith takes nice phones and videos too.
Okay. Good. So Judith, you're on the ball. Oh, I see what you took. Yeah. Okay. Dennis, do you have any questions?
No, not from me. I'm
All
ready.
right. So we wait. I think we have participants.
And I'm doing the close as well, Binta, is that right?
Yes, please. Yes, please. I think Josué left.
So the two speakers.
Je suis
just say-
toujours là,
non.
Binta.
Ah, tu es toujours là. Et tu pourras partir l'enregistrement?
J'ai lancé l'enregistrement, je vais me
Ah, tu as déjà
déconnecter.
lancé l'enregistrement. OK. Merci. Ah, merci beaucoup, Josué.
So for those who are speaking on the slides, just say next slide and then I'll move along. I might not be able to tell when you're done with that one.
Yeah, thank you.
Binta, how will we know when it's open?
I think the meeting is already open. I see attendees joining, and at exactly the hour it should open. Josue, is there another? Am I right? It's up to us to leave a few minutes before we begin, or to start exactly at the hour. I think the webinar is being recorded from what Josue told me. It's already being recorded here. I can see it. Yeah, it's already being recorded.
But
So
when the
it's
video is
open to
done, I
us.
can always edit, take out silences, things like that.
Yeah. Yeah. Yeah, people are starting to come in, so I think
Yeah,
we may.
I can see. Good morning, afternoon, evening to everyone. We're just going to wait for a few more seconds to let people join, and then we'll get started. I'll wait until we get to 30 and then we'll start. Okay. Good afternoon, colleagues, distinguished speakers, partners, and participants joining us from across the African region and beyond. My name is Dennis Mazingi, and I will be part of the group of people speaking to you today in this webinar. On behalf of the George Institute for Global Health and our partners at the WHO Regional Office for Africa, I'd like to warmly welcome you to session 4 of our webinar series on burns in children under 5 years in Africa. Over the past 3 sessions, we've traveled across the continuum of care by going through, first of all, the burden of disease in children in the African region and why these injuries remain an urgent yet often under-recognized public health challenge. We then explored prevention pathways and the actions needed to stop burns before they occur. And in the just finished session last month, we focused on early care and rescue, as well as treatment in hospitals, and what happens in the critical first and second moments after contact with the health system. Today is a very special session where we move on to the next chapter of the journey, which is rehabilitation and aftercare. This session starts from a simple but important idea that burn care does not end when a child survives. Across Africa, many children and families continue to live with the long-term physical, psychological, social, and economic consequences of burn injuries. And too often, rehabilitation services, psychosocial support, and community reintegration, as well as survivor-centered care, remain unavailable or inaccessible. This is essentially the continuum of care that we've traveled in our past sessions. And we have a very distinguished panel of speakers from across the continent and beyond who will be speaking to you today. Binta?
Thank you very much, Dennis, and welcome participants who have joined, distinguished speakers. I'll be the moderator for today's session, and I'll begin with a few housekeeping rules. So we'd like to ask all of you to check your audio and visuals. And before we begin, make sure you're on mute if you're not speaking. We're normally in a webinar mode, so you should not be able to unmute. But if in case just be sure to unmute if you're not speaking. We have a Q&A function and also a chat function. We would like you to reserve your questions for the Q&A function, but if you cannot access it, you can post some questions in the chat, and throughout the session, we'll try to address. We will have presentations and we'll have a section on discussions where you'll be invited also to ask your questions, and we'll do our best to keep time and also to attend to those questions. Please know that this session will be recorded and we'll be sharing with you all the materials after the webinar itself. It's a 45-minute presentation with a 15-minute Q&A, as already mentioned. We sometimes go overboard with our discussions. That's why I really encourage you to ask your questions as they come, and we'll make sure that we tend to them. So without further ado, I will begin by introducing my colleague, Dr. Chiara Retis. Chiara is a public health expert with a master's in public health from the London School of Hygiene and Tropical Medicine, with over 20 years of experience in international development across the Middle East, Central and Southeast Asia and Africa. She has collaborated with both government and non-governmental organizations in conflict-affected areas and also in low-resource settings. Her work focuses on capacity building and policy reform in physical rehabilitation, assistive technology, and disability inclusion. Since 2023, Chiara has joined us and is working at the WHO Regional Office for Africa based in Brazzaville, and is leading the technical work and strategy development on rehabilitation and disability inclusion. So welcome, Chiara, and over to you for this presentation. Thank you.
Thank you, Binta. And good morning, good afternoon to everyone. I'm very, very happy to be here with you to introduce, to give you an overview really of the role of rehabilitation, why it is important. This is a very important topic, of course, for survivors of burns. We do know that the consequences linked to simply to the healing process of survivors of burn can lead to a lot of limitations in functioning and then in participation in society. So because of the scarring process, so the process that helps the skin and the soft tissues to heal, very often, if no measure is taken, there are contractures to the limbs, to the joints that then limit the mobility. Of course, depending on the severity of the trauma and the burns, we can even have amputations of the limbs, for example. And we also need to mention the consequences from the mental health point of view because of the traumatic experience and because of this disfigurement that can happen for people, so leading to also very severe, isolation and social inclusion issues. So that's why rehabilitation matters, because rehabilitation actually can have a very positive impact on the outcomes of burns for survivors. We will talk a bit about what it takes to have rehabilitation implemented, what it means, who is involved, and then what is the current capacity in our region in terms of rehabilitation services and resources available. Next slide, please. So we said that rehabilitation has a big role to play for two reasons: to minimize the complications. So if rehabilitation can start early in the healing process, in fact, it can really help to minimize those complications that I have mentioned, like contractures, and can help maintain the joint mobility and prevent those contractures. But then for everyone, it can be a very, very long process that can last months and years. It can really help restore function and then social reintegration. There will be more an intervention by Dr. Alberta later about the importance of rehabilitation, especially for children, because of the age issue and the growing issue. Next slide, please. That is a very important point in our discussion today. When does rehabilitation begin? Actually, rehabilitation should begin really early in the healing process, even in the very first days of emergency care, in the sense that, for example, a good positioning in bed or preventing, working on edema for the limbs, which is a physiological reaction during the healing process. If we work on this through the intervention of physiotherapists, for example, at the bed of patients in the emergency care unit, but also through task shifting, so working with nurses and doctors and caregivers, this intervention can be very effective in preventing complications if they happen from the very first days. In the acute phase, and if there has been surgery through skin grafts, for example, when this is safe to be implemented, rehabilitation starts through, again, good positioning, splinting, which is the process that helps maintain the limbs and joints in a good position to avoid contractures, and pain management. We know that through early mobilization and good interaction between the patient and the health care workers, a lot can be done to manage pain, which can be excruciating for patients. So having a very big impact on the capacity to, move, collaborate, and react to the rehabilitation process. Of course, we need medicines and painkillers, but everything around the care of patient can really help reduce the pain. We have then a third phase, of scarring, the scar maturation that can last many months, and this is a key phase for the rehabilitation process, because during this time frame, through the utilization of compression products, skin massage, and active and passive exercise, we can really have influence the scarring process and prevent those contractures we were mentioning at the beginning. And then over time, and as we said, this can last not only months but years, working on assistive technology, functional rehabilitation, and then reintegration, returning to work, returning to school for children. So you see that the rehab is really a long process. It has to start early. It cannot be separated from the emergency and essential medical care and nursing care that is provided. And we shouldn't forget that the patient or the person, which is better to say the person, participation in the process is essential. The person and the caregiver, of course, and the family members. So we will always keep this in mind in the rehab process. The next slide, please. The multidisciplinary approach in rehabilitation for survivors of burn is the core principle. So there are many different professionals, but I would say competencies that need to be taken into account for a good outcome. So not only doctors, surgeons, and nurses, but also physiotherapists if they are present at the tertiary level of care. In burn unit or emergency unit, they should be there since day one. Occupational therapists and other rehabilitation profiles, when they exist in country, are very important. But again, here we are mostly talking about competencies, so either physios or occupational therapists, but also speech and language therapists when there are issues around swallowing, for example, and speech. And of course, psychologists providing support for pain management, psychological support throughout the process, and for coping strategies for reintegration. Slide, please. It is important also to mention the important role of assistive technology. Here you have a list of products. Some of them are quite sophisticated and expensive and maybe not available in some countries, but local solutions can be also found. And in any case, these are considered essential products. So we talk about splinting, orthoses to maintain the position that are provided externally to maintain the position of joints and articulation. We talk about mobility aids to help walking, but also prosthetics in case of amputation. Adaptive equipment to help people with burns in their hands, for example, to be able to eat, get dressed, and do everyday activities. Compression garments are quite specialized products that are used to help reduce the scarring process. Next slide. Observation around rehabilitation. When we talk about rehabilitation, this is a process, as we said. So it should, for burn care and for multidisciplinary care, this can happen at the higher, of course, levels of the health system, at the tertiary and then secondary level. But of course, the continuation of the interventions at the community level is also essential. Remember that this process doesn't end when people are discharged after sometimes many months from health facilities, but need to continue in the community. So referral systems are essential, not only for the first intervention, so to act very early, but also for the continuation of the process. And ideally, rehabilitation and the different interventions that are required should happen at all these levels of care if the referral system are in place. Next slide, please. Now, today, in the African region, rehabilitation is not really always integrated in health system, is not always integrated in an effective manner in emergency care or even in follow-up care. So this we can see it in policies. We can see it in the way it is funded. There's very limited funding for rehab and assistive technology. The coverage, unfortunately, yes, we can find rehabilitation professionals at the highest level of care, but still not available at the secondary and even primary healthcare level. Physiotherapists, occupational therapists, speech and language therapists, and psychologists, we do know that the density is very low. So we really need to work for now, not only to, of course, expand the availability of these professionals, but also to do task sharing with primary healthcare workers, doctors, and nurses to integrate those essential competencies in the pathways of care. Next slide. We lack share protocols around burn management and rehabilitation in this region. However, we can really rely today on some guidance documents that are very important, very strategic. For example, we do have a regional strategy for rehabilitation that was endorsed just a year ago by member states. So remember that in your countries, ministries of health should work to strengthen rehabilitation services. We do have some packages of intervention for rehabilitation that provide guidance on what are the essential interventions, how they should be delivered. For burn care specifically, we do have a lot of guidance around emergency and mass casualty interventions rather than, let's say, routine care. But you will find in these three documents, like the standards and recommendations for burn care in casualty incidents or early rehabilitation in conflict and disasters, and also emergency medical teams standards, they all present very clear recommendations for rehabilitation interventions, what is needed, who should provide it, how and when. So I invite you, these documents are available online and they will be shared, and I invite you to also have a look at those when you have time. Next slide. I'm just running because I'm conscious of time. So there are opportunities to strengthen rehabilitation in for burn care through advocacy for inclusion of burn rehabilitation in national health policies. All the policies related to injury prevention and management, but also emergency preparedness and response. So do consider these as entry points to strengthen burn care. And then any opportunity to really link burn rehabilitation in existing emergency care packages, strengthening referral pathways, work with the professional associations in countries with them, because they do have also professional standards of care for burn that can be an entry point. And Dr. Alberta would say more about that, about the role of professional associations. And we always need to showcase what it means, the value of rehabilitation in improving functioning, in improving inclusion. We do need to generate more evidence, so everyone is welcome to also collaborate with us to develop more data on rehabilitation. And so just to conclude, rehabilitation works. It is very effective in improving the quality of life of people, of survivors. We need to strengthen rehabilitation services, and we know how to do it, and we can do it in collaboration with all the actors, the professionals that are present today, and the networks available in the region, and of course the policymakers. Thank you very much.
Thank you very much, Chiara, for this great overview of rehabilitation. We're really now into a new topic compared to what we have seen in the previous sessions. And thanks for reminding us of the continuum of care within rehabilitation. It's not only at the end tail of the process, but really has to start early on. So thank you very much for this. And I think you already announced our next speaker, Dr. Alberta Amisanyarko. I'm happy to welcome you with us in this session. Alberta is a Ghanaian physiotherapist and burns rehabilitation specialist with nearly 20 years of experience in clinical care, training, and humanitarian response across Africa. She currently serves as Vice President of the World Physiotherapy African Region and was co-chair of the Emergency Subcommittee at the WHO-hosted World Rehabilitation Alliance from 2024 to 2026. Based at Korle Bu Teaching Hospital in Ghana, I hope I pronounced that right, since 2007, she has supported burn rehabilitation services and emergency responses in several countries, including coordinating rehabilitations for survivors of the 2021 Sierra Leone tanker explosion. Alberta is currently pursuing a PhD, but I think you've earned your PhD already from the University of Witwatersrand in South Africa. Really happy to welcome you as you give us, the practical, concrete, everyday experience of rehab in a hospital setting. Over to you, Alberta.
Thank you very much, Binta. Good morning, good afternoon, and good evening to all our participants. Thank you for joining us today. I bring a different highlight into how we can see all the challenges and the problems we have, and actually how we can give a one-directional approach to it, which is practical, effective, and gives results. I represent Interbenz as the rehabilitation lead, and Interbenz is a UK charity founded in 2006, focusing on training, education, research in low-middle income countries. What is fascinating here is the fact that Interbenz uses a global widespread of faculty, whereby we have Africans, Asians, those from Europe, and from USA. Why is Interbenz being highlighted even though we are in Africa? Because as we find ourselves in Africa, we know that there definitely is a significant challenge when it comes to pediatric burn rehab management. These challenges include, just as Kiara has mentioned, in our workforce, in financial burdens, in the limited equipment we have, in our delay in referral systems, in our psychosocial burdens, and even in the chronic phase, we also have to consider the inadequate follow-up systems. Usually, for an effective pediatric burn rehab, it would not just aim at making sure that wounds are healed and patients are back into society and community, especially our pediatrics, back into school, having their play and learn and fun. But then we need to make sure that there's quality in all of this. And this quality simply means that we are maximizing their functional recovery. We are preventing any long-term disability. We are, even as rehab specialists, supporting their psychosocial and psychological well-being. And then at the end of the day, as the ICF model always guides us, to be able to facilitate reintegration into family, school, and community life. Next slide. These challenges have already been highlighted, but then from the Interbenz perspective, I want us to just have our minds around these various challenges again, because what we see in Africa is that very few people, there are even very few rehabilitation specialists in terms of physiotherapists, occupational therapists, some speech and language therapists, and even psychological therapy. We would realize that there's very limited access to even these people, professionals who want to actually specialize in burn care. Every time Africa is mentioned, financial constraints come. But then to who? It's to all of us, both the patients, the caregivers, and even the professionals at the hospitals, at the health posts, at the district level, who wish we could have all that it takes to handle a patient. Then what we need to use to handle these patients, which are in terms of our equipment, our materials, are also very scarce because we are not producing much on the African continent. Then our patients are attended to at the inpatient level. Now, depending on where they come in terms of location, referral becomes a big issue. And then even before they arrive to us, there is a big stress on late presentation. We are not delving into late presentation today, but then it is one of our challenges because how we wish to be able to have functional recovery is dependent on actually how the acute phase is handled, how the injury is handled. So even late presentation is one of our challenges that we need to solve. Then our poor long-term follow-up and management, our high burden of contractures that might set in, and then the psychosocial and mental health challenges that prevent our patients from being their best and getting back to their pre-burn state. But this morning, Interbenz wants to highlight on the workforce training gap within the whole African continent. Next slide. So again, Interbenz is a group of great global faculty that wants to train, educate, and move into research. What kind of training and capacity building have we enrolled on? We have courses labeled as Essential Burn Care course, which usually runs for just a day. This Essential Burn Care course actually incorporates the multidisciplinary team, as Kiara mentioned. So the fact that we have seen that there's a challenge, one, there was referral system challenges. Two, there was proper MDT management challenge. So Interbenz has captured on this to make access of essential burn care to professionals who see burn patients but have no formal training in burns management. So we'll call it trying to handle district level professionals. So these district level professionals now have an essential burn care course, which has a component running from surgical intervention, nursing intervention, psychosocial, rehab intervention, and then it even has that component that we always forget, which is the patient-centered component in there. So this is for all the basic professionals to appreciate when it comes to burn management, how we practically involve the MDT. Then we move on to a higher course, which is for burn specialists who are within burn centers, but haven't gotten the opportunity to actually have proper training within burn rehabilitation. So they would have a whole 5-day program. This 5-day program breaks down into the perspective of being able to identify the advocacy component, the health promotion, the health prevention, the prioritization of these burn patients, especially these pediatric burn patients that come to us at the hospital and even before they get to us. And then delving down into the practical, doing the cardiopulmonary rehabilitation for burn patients, looking at all the models, of positioning, of exercise therapy and prescription, of splinting, and then moving further on into its long-term management, which involves the scarring, how to prevent these scars and how to manage these scars when they come. And then we engage the patients themselves. So we have a survivor session within the 5 days for us to appreciate what the survivors think, how we can support them even after they have been discharged back into society, and then how much our health professionals, in terms of our rehab specialists, also appreciate the fact that when we say long-term management, it doesn't end on discharge, but it ends on follow-up until we get patients back into society. So just this training and capacity building, which I can highlight that we have been able to do EBC in more than 10 African countries. I am going to mention a few because I believe that we have few of our participants starting from Ethiopia, from Tanzania, from Senegal, from the Ivory Coast, from Ghana, from Malawi, from Uganda, from the Gambia, and from Sierra Leone. We can proudly say that we have trained the multidisciplinary team in essential burn care course in these countries. Then again, when we come down specifically for rehabilitation specialists, then with all these countries, I'm going to add Benin, Botswana, Nigeria, the Ivory Coast, and Rwanda. So rehab specialists in all the above have been trained in advanced burn care courses. Now we are trying to break that gap, and breaking that gap, knowing that Africa has a lot of financial burden. So this training that Interbenz runs is absolutely free. You only need to see the application, you need to apply, be shortlisted, and then you would be invited for this 1 day or the 5-day training program. We are not stopping at just training as professionals, but we are moving on to take them to a next level of trainer of trainees. So we actually run trainer of trainees program so that not that they stop as being participant, but then when they go back into their countries, they would be able to actually harness their hospital into bringing that MDT together and knowing how to do internal training. With knowing how to do internal training, we have a system called a DAT, which is the Delivery Assessment Tool. This delivery assessment tool is a way of getting the hospital itself and their MDT with their management to appreciate being able to identify their own gaps and finding a way to track these gaps over time and to improve upon it. So this is more like empowering the hospital to be able to do their own initial assessment, plan on how to go about the challenges that they have documented. And with our support, we would be able to guide them through how to improve upon how different areas, 10 systematic areas, 5 clinical, 5 non-clinical, are being run within their hospital. So this is how Interbenz is able to go down into country level, into hospital level, to support rehab care, MDT approach. So not just even the rehab, we further on move into nursing and surgical. We again have a great rehab force development. So when you come down to Interbenz Rehabilitation Faculty, we can proudly tell you that we have trained therapists from all over, and some of these mentioned African countries actually have faculty that can be able to support training within the whole Africa and beyond. We do run mentorship and clinical partnership. Clinical partnership because we give access, we give direct access to all the people trained, such that on any day when they have issues of burn management, they just place in a video call, place in a WhatsApp, and then we support them within their countries. So it's direct mentorship to be able to sustain how we break the gap of workforce development into their African countries. Then we create a big networking whereby you could easily find somebody in Liberia, somebody in Sierra Leone, who we can link together to support in terms of humanitarian response or any other conflict or emergencies that comes about. We also are into research and evidence-based practice. So we do not leave you at training you or making you a trainer of trainees, but we encourage you to bring up little surveys so you can appreciate how work is being done, what you are doing, if there could be any improvement, any sustainability approaches to help guide what you do. So at the end of the day, we have better patient outcomes because it is self-initiated. Lastly, as we all know that we always stay at the hospital levels and then we forget about primary health care. Interbenz is bridging that gap as well. It's bridging that gap through our basic burn care programs. These basic burn care programs are usually run at school levels and community levels, whereby we think about advocacy, we think about burn prevention, we think about first aid promotion. And it's always best to deal with pediatric by making them know that it starts with them. The advocacy, the education starts with them. So this is the practical perspective with which Interbenz has been able to interlace and found themselves penetrating different African countries to help at different levels to make sure that we are strengthening burn rehabilitation, and not just for the burn rehab professionals, but even going down to strengthen MDT approaches or MDT management. So next slide. So these are just few evidence. And then even when it comes sometimes to the product and equipment, Interbenz is also able to support with pressure therapy in few of the African countries. And it's hopeful that in the nearest few months to years to come, we are going to expand how we can support different countries in trying to get their own pressure garment, because the aesthetic effect of our burn survivors goes a long way into achieving full functional outcomes. Next slide. I wish that if not for nothing, we should be able to appreciate what education, what mentoring, what sustainable partnership can do in improving burn care and rehabilitation outcomes for children using the interburn approach. Secondly, we should learn to invest in innovative, low-cost, and community-centered approaches, because in Africa, we tend to listen to community members. They have a lot of influence in our healthcare delivery. Lastly, we should strengthen our rehab services. And strengthening this is definitely through our multidisciplinary team care approach. We should remember that wherever a physician finds themselves, they should always know there's early intervention. And this early intervention is because we are pulling everybody along and not getting to others too late. We are getting our local capacity strengthened. We are involving our community in advocacy, because at the end of the day, we want to have better functional outcomes, we want to have quality of life and social participation. I'd like to thank you all for listening to me. I'll hand over to Binta.
Thank you so much, Alberta. This is a very good key takeaways, because it brings us back even to the first sessions that we've had in this Burns webinar series, where you talk about, of course, the challenges, but also the importance of community, of prevention at early stages, in all settings. Actually. So I think it's a very good introduction to the next session that will begin now, which is the discussion, and where we'll bring in additional speakers, survivors, the mental health that you've all also indicated. Then I just realized that I actually did not introduce myself. My name is Binta Sako. I'm a technical officer at WHO Regional Office, where I'm in charge of violence and injury prevention. So I'm very happy to bring in addition to Chiara and also Alberta, I'd like to bring in additional colleagues. So please put on your cameras. Please help me welcome Judith Kato Addison. She's a Ghanaian burn survivor who accepted to be part of this session, and we're very grateful. She's an advocate and founder of Beyond Burns International. She leads efforts to advance burn prevention awareness and survivor empowerment across Africa. Drawing from her lived experience, she works with government institutions to promote safer communities and influence public health conversations, and ensures that burn survivors are included in health and development agenda. So welcome, Judith. Very happy to have you among us. And in addition, we've also invited Dr. Chido Rafa. I'll stop there, Chido. I cannot pronounce your other last name properly. So Chido is also our colleague from WHO Regional Office. She is a consultant, psychiatrist, and public mental health specialist, and currently serving as the mental health regional advisor in Afro, supporting the 47 member states to strengthen mental health systems. She's a keen advocate for mental health, and you'll be a witness to that, promoting greater awareness about mental health and well-being at individual, family, community, organization, and policy maker level. So welcome, Chido. I think you're essential to this conversation. So we were very happy to have a panel of women with us today. We'll discuss, all that. We'll dig in a little bit deeper into what has already been discussed and expand, of course. I'd like to invite colleagues, please put in your questions. It's really important. I think as the time is going, we may have time to take also a few questions here. So let me begin with Judith. And once again, thank you for being here with us. We'd like you to share a bit of your experience, as a survivor, and also help us understand what were your biggest challenges. What were the biggest challenges that you faced after surviving a burn injury, and not only physically, of course, more holistically, socially and emotionally. If you can share as much as you're comfortable sharing, of course. Over to you.
Hi, everyone. My name is Judith Kato Addison. I'm so happy to be here. I'd like to begin with my story. When I was 10 years old, I had just come back from school one December. I met my mom sitting in front of her shop, which used to be in front of our house in Abosukai. And I told her I was hungry. I hadn't eaten all day. And we concluded I could make some yams for myself. So I went into the kitchen. At that time, we had a very small kitchen and a tabletop stove and the cylinder right beside it inside of the kitchen. So I went in, cut up my yams, put them on fire, and I waited. Being a child, I would check every 5 minutes to see if my food was well cooked. But one set time when I was checking, I noticed that the napkin that I was using had a thin film of smoke coming out of it. I didn't think too much about it. All I thought was to get my food. So I reached out to touch the napkin to take it and check my food, of course. And before I could remove the napkin from its resting place, I heard a loud explosion and my body was on fire. There were some people in the house. I was screaming and they came, they poured water on me quickly. At the same time, my dad had just walked in from work that day, unusually early. And when he saw me, he just put me in the car and they drove me to the Kolebu Teaching Hospital. It was there that my journey began. We got to the hospital at 3:30 in the afternoon. And by 10 p.m., no one had seen me. And I just got worse with time. Later on, they started treatment. I think I woke up and realized my body was in bandages, my legs, my hands, and my face. So the burns affected my face, my hands, and then my legs, as said. And it was excruciatingly painful. That was the most difficult part of treatment, was going to get dressing. Back then, the Kolebu Teaching Hospital did not have the reconstructive plastic surgery unit that it has right now. It was a children's ward, the children's block. And then there was one of the rooms that had been designated for burns. So all of us were there, children, adults, everyone was in that room. And from everywhere you are around the block, you could hear people crying every morning because of dressing. This was very uncomfortable. Another thing was the smell from the wounds. At some point when I was discharged to go to school to join my friends, I'd share, it was bunk beds. I went to the boarding school. It was bunk beds. And sometimes because of scheduling, there was an arrangement with the school so I could go to the hospital to get dressing. But because of scheduling, sometimes people around me would even be uncomfortable with the smells, even myself. And then the itch. The itch was very, very uncomfortable. Sometimes we'll put our hand through the bandages and then we'll scratch and get new sores. Many times I'll ask if there was nothing to give for this, to make the itch, go down. But we had to live through the process back then. And it took so many years to get completely healed from the burns in terms of the wounds. I mean, it took up to 2 years to get all of my bandages off. The burns left some scars and keloids on my body, most of which I managed through compression. And then another thing was the contractures. I had some on my hands, and in class, it made writing very difficult. Yeah, that was it. And then getting back to school, it was another difficult part of the journey. I remember the first time I went to school, I was leaving my old school for a new one when this happened. And we had done all the administrative work. And finally, before entering the class, there was nobody to sensitize the students, let them know that there's somebody coming that's a little different. When she comes, do not be like, you have to be nice at least. Basically, nobody said anything to them. And because I was so excited to enter a new school, I was dealing with a lot of frustration with myself and with everybody around me before I went to school. Actually, that was why I opted to go to boarding school. Everybody around pitied me when I came back from the hospital. The welcome home was that everybody wanted to see, but I noticed that nobody knew what presentation of burns and the severity of burns could be like. So when people came home to see me, they expressed their shocks and their fear. And that deepened my emotional pain. They didn't think what that would have, like what kind of effect it would have on my self-image. And my parents themselves had gone through so much financial struggle through the whole process. And they were dealing with that and dealing with a new girl that was becoming more reserved, more withdrawn. didn't feel understood. So there was practically nobody to talk to about this. So when I heard about the boarding school, I wanted to leave the house, basically. That was why I wanted to go to boarding school. So going to class, I was so excited. Nobody prepped the children. I got in there, and then the exclamations, the yelling, the comments, the whispers. I just broke down in tears. I started crying. My dad was so upset. He wanted me to leave the school at that time. But I was bent on having a new experience, so I stayed. And while in class, I think that what helped was the way I participated in class activities, my contributions to discussions and everything. It started making the children look at me a little differently than not just a burn survivor. There's more to, there's a human being, behind that person. And that made it easy for me to stay. But I think that the whole time I was also treated like I had a physical disability, because nobody considered my potential to lead or be responsible for anything. They just put me on the sidelines. When there were games to play or any like physical activity, there was no alternative arrangement for me. So I just sat down, isolated a lot of the time. I think that was what also informed their thinking of what I was capable of doing. And so that happened while I was in primary school. Growing up, there has been some missed opportunities and challenges. I remember one time in the university, I had a conversation. I've been having conversations with a gentleman for a period, and he was excited to meet me because I arranged a meeting with at church. He left his town, which was a far away place, and we're meeting close to the church so we could go together. I got to the place. He saw me. He was shocked. He couldn't handle himself well. He could barely get his words out. And all he said was his mom had sent him to do something. It was just hello and bye-bye at the same time. And I never heard from him again. And there was a time I wanted to apply for this job opportunity because I needed the money while I was in school. And when I made the application, I went. It was a 3 days training before the main event, which was the AU Summit happening in Ghana. I wanted to be an usher for the event. The wage was good. I went for the training all 3 days. And finally, on the day when we're supposed to enter, to actually work, I was isolated and told that I couldn't go on because of my scars, that it would make the people we are receiving, some of them, feel uncomfortable. It was at this point that I noticed that this whole thing could have a very dire effect on my career opportunities. It had never occurred to me till that point. I mean, other things had happened, but I never considered it in the way I considered this missed opportunity. So there was that. So we've handled a lot of emotional pain, and we handle it as survivors all of the time. Most of it being the rejection, the isolation, discrimination, exclusion, basically. And most of the time, it makes us internalize a lot of the things that we have been through. There's the self-doubt and withdrawal that is there. We had no professional help through this process in terms of a psychologist. Both myself and my parents needed that psychological attention or help, but none of us got it. And I don't think my dad recovered from the process, the whole thing, before he passed on. My mom recently confessed that she hates herself for having cried a lot of the time through this, because when she looks at the activities we are doing now through Beyond Burns International, our collaborations with the Kolebu Teaching Hospital, the Ghana National Fire Service, when she looks at all the things that we are doing for survivors in terms of skills training, psychological support through our burn support group, she feels like she wasted so many years wondering whether I was going to be fine. But I am now. I'm glad to be in this position. Thank you for inviting me to be part of this panel.
Thank you. Thank you so much, Judith, for your testimony. I think you covered, you're a living example of all that we've been talking about, all the challenges that we're facing in terms of delay, in terms of the long-term care, in terms of the gaps that we see in our health system. So thank you very much for sharing this with you. I think, it's these stories that tell us that, we're doing the right thing by investing in this kind of work that we do. And I'm sure, Chido, you'll concur. A lot has been said around what you also tell us about the work in mental health. So, as Judith mentioned, this are long-term psychological trauma. What are the most critical gaps that you see in the mental health support that survivors in general and burns perhaps in particular live in the African settings? Can you also maybe open up to feasible, easy, well, it's never easy, but solutions that you see that are lower hanging fruits for low resource settings to put in place that can help support people who go through the experience Judith went through?
Thanks so much, Brinta, and just a really big thank you to Judith for sharing your story. Stories of lived experience ground us. They ground the work that we do. And I think you've already touched on a lot that I'll talk about already. You've illustrated it. I'll backtrack a little bit and just say, even before someone has a burn, we have a high burden of mental health conditions amongst young people in the region. 50% of mental health conditions start before the age of 14. Then you add a burn, a severe burn, you are now just increasing the risk of developing a mental health challenge. Judith mentioned emotional pain. This is some of the consequences of burn. So it's not just the physical burn, the scars. There's deep emotional, psychological scars that come from burns, issues around body image, issues around depression and anxiety, trauma-related conditions, and not just PTSD, so post-traumatic stress disorder, which is what we often think about. But there are things like adjustment, just adjusting to living with the consequences of a burn, acute stress disorder that often happens in the first few weeks, and then post-traumatic stress disorder, which happens in some people. And then prolonged, complicated grief. I think Judith mentioned her father struggling to recover from this emotionally his whole life. So prolonged, complicated grief. We don't just grieve people who've died. We grieve things that we have lost or a life that we thought we could have had. We also grieve that. Then coming to your question on key gaps. So the key gaps for burn survivors in terms of mental health and psychological support is very similar to the gaps that are there in the mental health system. I'll highlight the issue of limited integration of care. So when a burn happens, I think Judith illustrated it well. It's the physical health that is usually the priority. We're trying to keep this child alive, keep this person alive. Everybody's a bit on edge in terms of the physical health side of things. That sometimes the psychological care becomes neglected. It becomes a secondary, of which it's not. Just as Kiara illustrated that the rehabilitative care starts from in the acute phase as well. It's the same for mental health care. It should actually start in the acute phase as a person is being received in hospital. What sort of care is being provided at that point beyond the physical care that we need, and not only them but also their caregivers, the people who have brought them in as well. And some of the gaps there in terms of integration, it's not just burns care. Across the physical healthcare spectrum, even primary healthcare, there's no integration. Only 7 countries in the African region have effective primary care integration. And what do we call effective integration? It means there should be a guidance, an SOP, standard operating procedure of how do you provide psychological care when someone gets burnt. Training of non-specialists. So the psychologists may not be ready in the office or may not be available. There's a severe shortage I'll talk about. So the person who is available, what can they do in terms of psychological care? And then have making sure that some of the training, we know the MHGAP training guide provides that training. The MHGAP, the Mental Health Gap Action Program, has got a standard intervention for non-emergency settings, but there's also a humanitarian guide that actually includes some of these trauma-related conditions so people can be trained in how to manage. These are non-specialists. And then also being able to be trained in trauma-informed care, in psychological first aid, in screening of common conditions, like I've mentioned, the depression, anxiety, the trauma conditions, the grief, or the complicated grief. And then support and supervision and mentorship. Just because you train the non-specialist doesn't make them a mental health specialist. So that would be task dumping. You want to be able to support them, the few available specialists to provide that support. Availability of psychological interventions, yes, but also medications when they're needed. If depression is diagnosed and it's severe, it needs to be treated. If anxiety is diagnosed and it's severe, it needs to be treated. And it's also just as important because in terms of recovery, untreated depression, untreated anxiety will complicate things as well. That shortage of specialists, we've got 2.2 mental health specialists per 100,000 in the region, and less than one psychiatrist per 100,000 population. So we're not going to have enough of those people in the next couple of years. Easy ways, task sharing, training in image gap. These are approaches that we can take. They're low-hanging fruits. Image gap is actually available online on the WHO Academy. So this is something that we can already institute within burns units to say it's important for someone working in the burns unit to have done image gap training so that at least they know the basics around mental health and they can provide care. I want to just highlight specifically the issue of, well, before I go there, the training of the specialists in supervision. So sometimes the specialists don't think that this sort of care, the liaison psychiatry, going to the burns unit is part of their routine care. So they also need to be educated and trained to say mental health across the health system is also your responsibility. Don't just stay in the psychiatric units so that there's a genuine integration. Then there's the issue of trauma-informed care, which we don't always talk about. How are we creating a safe physical environment and psychological environment? Many times burns unit are isolation wards. It's very lonely, very isolating, very scary, especially for a young person. Is the room, the ward that we are using psychologically safe? Are we building trust? Judith mentioned the dressings, the screams from the dressings. What can be done to limit that pain? Because that creates trust, it creates safety. And then also choice. Sometimes because you've got a burn and we have to dress it, then you have no choice. We always need to create situations of choice. What choices do I have? That also creates trust and creates a trauma-informed process. And then being culturally sensitive, being context specific to this particular family. What does this family need? What does this person need? To close, issues around stigma. So even when stigma is an issue for mental health already, we're still in a burn survivor. And for people to then reach out for help, it often is a barrier. What will people say about us? What will people say about me? And even if it's body distress or body image issues, sometimes there's stigma there to say, how can I go and ask help about this? There can be stigma around that, and that needs to be addressed through community engagement. And then the support systems. And congratulations to Judith for the organization that you formed to provide that peer-led support. And people actually can talk to someone who has been through what they're going through and feel like they're heard, they feel like they're not alone. This is very, very supporting as well. And finally, care for carers. I think Judith illustrated this. It's the child or the young person or the person who's survived the burn, but the greater family also needs to be supported. Back to you, Binta. Thanks.
Thank you so much, Chido. And you really you're a mirror at a different perspective of the same thing between you and Judith. I think you've really covered the same elements that are so essential to survivorship. And I also see a lot of resemblance between the psychiatry, mental health, workforce challenges and the rehab challenges as well. Integration, workforce, tax shifting. It's the same issues that are really coming up in both your discussions. So I'd just like to take it a little bit further, and Chiara, and maybe look at the element of equity that hasn't necessarily been discussed openly, because we talk about shortages, we talk about lack of integration, but we also know that in our context, the services are available in urban or much richer settings. So in rural areas, we really lack everything. So what do you think could be solutions to address those inequities, and make sure that everybody has at least a similar or minimal access to care? Do you have any insights into that? And perhaps, Alberta, you can also chip in.
Binta, you asked a very, very difficult question. Okay, so this is at the heart, I think, of any actually health intervention, and specifically, globally and in this region, meaning that the availability of essential, person-centered healthcare services is very limited, we know, in rural areas, as you have said. So from a public health perspective that I can bring around equity, there's a lot of emphasis today on universal health coverage and decentralizing and strengthening the availability of essential services at the primary healthcare level. So to achieve this, because this is a way to increase, of course, equity among people, among the more vulnerable, of course, individuals or groups of populations and communities that we know. So to do so, the strategy is, for example, to do task shifting. So as also Chido mentioned, look at the available personnel and really strengthen their essential competencies of basic intervention that can be provided at this level of care. I'm talking about the health system, of course, but we need to think broader out of the health facility and the community, because what we heard from Judith is that the daily challenges of survivors of burns are in the every activity and experience during their life at home, on their way to school, on their way back to school, to workplace. So we need to think about, when we say decentralize and make sure that essential services are available at the primary healthcare, we mean yes, in health facilities, but also in the level of awareness of community health workers, for example, and the community in general around the needs of people in the community. So it's really a shift in the approaches, from yes, we do need multidisciplinary care. Yes, we do need specialized quality services designed on the needs of people, to be centered around people needs. But we also need to always think about how this translates at the community level and create all those links. So, yeah, I mean, in short, on your very difficult question around equity.
Yeah, I appreciate the difficulty of the question, but I think and a previous speaker in one of the sessions said also, we cannot have the Rolls Royce all the time, so we have to do with what we have. I think that's the general message, as long as we have that equity lens in mind. Alberta, do you want to come in with a few additions or complementary comments?
So I think in trying to reach the primary health care, we need to appreciate what is culturally accepted. Most of the time, people would have injury, and the first place they would want to call on would be the spiritual leaders or the community leaders. So in 2025, Interburns was in Gambia, and the group of people that we trained in essential burn care course were spiritual leaders and community leaders. Someone might think that we're a bit crazy in thinking to go to them when we could have just used possibly private the primary health care nurses or community health care nurses, because we do not have rehabilitation specialists within the rural areas. So you have to go down to a level of multidisciplinary team professionals whom are not, quote unquote, too busy to be able to learn added roles. So I think we should just look at what works within the community, who the people would go to, who they listen to, and then do the advocacy or empowerment to them, because they will definitely get there for the first aid. And that is what delays them in actually getting to the health post, the health centers, or the specialized burn centers, which are not available within Africa. So let's look at the other areas where we can train. Because for me, it's mostly about educating and empowering the people to do the right thing, because you do not have all the professional groups to be there within the time, because training burn specialists is expensive. And I believe we would get there soon. Thank you.
Thank you. Thank you so much for, opening the box. You're really thinking outside the box. And I hope Interburn's documented this experience. It's really interesting and should be disseminated that there are other ways of doing things that work. So congratulations for this. I'd like to ask another question to Judith. And I think, you have an organization that's doing advocacy and that's doing peer support. I think you're the best you're the best person to ask this question around how to effectively integrate victims of burns back into society so that they can perform fully. Your story is a story of resilience and yourself finding ways of doing exactly this. But how would you see a system built that would help any survivor to be better integrated into society? What do you think are the ingredients that are needed to do that?
Hi everyone, once again. I'm happy to be part of some organization that does this. I'll be happier if this becomes a national agenda, a global agenda for everywhere you are, that there has to be a rehabilitation service for burn survivors that supports survivorship, not just the confines of the hospital, but beyond that, survivorship itself. Going back to school, in our educational service, we have to know that not everybody is going to come out looking like your regular person. And the children ought to know this. The sensitization is very important so that when they meet survivors, they know how to show up for them, showing empathy rather than sympathy towards them. And the whole shock thing is because there's very little awareness on the presentation of burns and the severity of burns. Burns can affect anyone, regardless of who you are. All you need to do is to be somewhere that there's a fire, and then you just qualify to be a survivor. That's it. So to be more empathizing of the situation will help all of us. There's the need to get rehabilitated. So if somebody has a burn and they are leaving the hospital and they have contractures that they cannot afford, what system is there to help them get their surgeries done, their contractures released to promote function of their body parts? There has to be it shouldn't be tied to your socioeconomic status, because then many people cannot afford and then they tend to withdraw from school and from work. How to get back to, so in school, teachers have to be aware of these things, how to schedule you so you can have your dressing done, at the same time participate in class. Are there alternative forms of games or play when there's physical activity time? Is there something else you can do so you do not feel rejected or isolated or discriminated against? These are important for our school system, the sensitization and that. And for work, coming back to work, are there flexible hours for people who have burns? The whole period they have to take away so they treat themselves. Is it that because you've been away for 6 or 8 months, now you have lost your job? Because then how do you survive after that? Reintegration is very important. Having peer support groups then on a more national level, that allows people to know that there's a sense of belonging here. There are people who have been through what I have been through here. They understand myself and story. And more importantly, there are people that are thriving in the situation. So you can also do the same. It's very important. Offering the psychological support, the service has to be available for everybody to reach, not at a fee, not limited by your distance, so that I have to pay for transportation and I do not have that money. So it should be very available, even within the CHIP centers that we have in Ghana and across Africa, so that people can easily access these services, have someone to speak to about these kinds of problems. The need too for burn survivors to lead advocacy is there, because they are living and working examples of what we are talking about, trusting in their abilities to take up these responsibilities as ambassadors, as leaders of this cause, backed and totally backed, supported to do these things, because many times funding becomes an issue and many people start and then they give up along the way. If we want to do this, we have to tackle it from everywhere, but these are what I'd want to put to the fore now.
No, thank you so much. And I think it was alluded to, but you really highlighted the financial hardship for the victim. We're talking about gaps in funding, in services, but we forget that a lot of these services are out of pocket, and that has implications. So thank you for reminding that as well. We're reaching the end of this discussion session before we open up to a few questions and we close. And I'd like to ask all of you one, very short, one thing that you feel should be a priority for countries if they want to improve burn survivorship. So what should the countries do? One thing. Let me begin with Judith. One thing that you would ask your government to do.
To have a national burn survivorship and rehabilitation program to start with.
Thank you. Chido.
A guidance document for how to manage burn survivors right from the acute phase into rehabilitation and recovery.
Thank you. Chiara?
I would say integrate rehabilitation services in the broader sense into the essential packages of care, because this would allow to reduce the financial barriers to access and have the essential interventions at the primary health care level.
Thank you. And Alberta?
So I'll say that everything boils down with funds. So we get the government to put burn care in terms of advocacy, promotion, prevention, treatment, and investing in the training of all professionals at all levels of the MDT into their national budget. That would do for us.
Thank you very much. And you're already announcing our next session next month, the importance of funding. So, dear panelists, thank you so much for being here, for sharing your experiences, your insights. This is really valuable. I'd like you to stay on because we have a few questions from the chat, and I'll go through them. There was mention of the need for advocacy for further policies and investment into burns care. Totally agree. Do the speakers have any examples of this having occurred in the region and therefore lessons that can be shared? And in addition, where does that advocacy most need to be directed? Towards finance ministry, development partners? I think this is an excellent question that Alberta, you touched on. So maybe you could have a response to it.
Thank you for the question. So yes, advocacy is at different levels. You could do the primary, secondary, and then the tertiary. So primary advocacy is getting down to the people themselves to let them appreciate what we can do at the community-based level within and amongst ourselves in terms of health professionals getting to the schools, as Judith mentioned, and then getting to the other health posts so that the other MDT members could at least know how to refer, when to refer, and to do the right direction. Then you could come to the secondary, whereby the professionals themselves have level of training so they can meet the needs of the people. And then tertiary is trying to get into the government, bringing them on board as stakeholders, letting them appreciate the reason why this the reason why burns in itself should be captured under what we call the national health insurance policies, and then knowing why there should be like a preventive program for the burns. I say preventive program because it is easier having funds to prevent burns than actually having a location to treat the burns. Because as you said, financing in burns, if we should even look at a child of less than 25% burn in an ICU for a week, it's more than a health professional's salary. I believe even just spending a day there is your whole monthly salary. So if you start calculating that, you'd realize that if you do not get this advocacy at different levels, you cannot really succeed. And you can't push everything just to the government level. Let's try to do what we can do. Let's try to get our NGOs, our stakeholders involved, our partners, and then the final call will be the government to give a bigger national policy or advocacy towards it. Thank you.
Thank you, Alberta. The question was from Blaise Murphy. I have another question here. Can effective burns care start before a burn injury? I think we talked about prevention. Does anyone want to do a quick response to Ayodeji Lisi? Chiara, do you want to take the response?
Yeah. So prevention and preparedness, I would add this keyword, meaning that if everyone, every relevant actor at the community level, starting from primary healthcare workers, are aware of what needs to be done or not to be done, and also have an idea of the long-term needs of burn survivors, then this can really smooth the pathways and the journeys of survivors of burns.
Thank you. Thank you. Another question, I'm taking them a little bit quickly so that we meet the time. I have a question from Juanita Nalungoji. The research team working with us got mental health challenges and equally needed counseling due to the suffering the patients undergo and the unexpected mortality. Do you see this among the carers of burns patients? Is there counseling for the carers, meaning the health facility staff? Chido, this is for you.
This is a really great question, and this is a huge gap. Usually, care for carers, particularly healthcare workers, is not something that is prioritized, and this is part of workplace mental health, because working in a burns unit is it's a workplace hazard in terms of your psychological health. So it's one thing, when you're coming to visit someone, let alone someone who works in that ward every day, day in, day out, their psychological health would be at risk. So they are higher risk, and they need specific attention to these workplace hazards, and that should be part of their workplace package. Employee assistance and regular check-ins with mental health teams. So yes, and someone coming in, I think the research team that was mentioned, that needs to be part of preparations. If someone is going to be coming to do research in a ward like a burns unit, they need to be prepared for what happens in a burns unit. So many times so that you actually come in with that knowledge and understanding. And if they then develop challenges, they can then get the support that they need. Just to mention trauma. You can get trauma-related conditions even if you're not the one who has experienced the trauma. So you can actually get post-traumatic stress disorder, you can get acute stress disorder from witnessing the trauma happening to another human being. It's what makes us human. If someone else is suffering, I suffer with them. So that is actually a real risk that we need to be aware of. Thanks.
Thank you very much. I'd ask panelists to look at the Q&A. There are questions that are a bit technical, so I may not take them in the call here right now, but I have a few comments that I'll read from Joseph Capuchichi. We must continue to raise awareness starting in elementary school. I propose that short videos be produced to draw the attention of the public as well as government officials to the holistic care of disabling conditions such as burns. In most of our countries, some policymakers believe that the only requirement is that the person be alive. Nothing else is taken into account. I think this is a very true statement that we all know. Chiara, I saw you nodding. Do you want to add something, or did you want to make a comment?
Just yes, to comment on the fact that, for example, pain management today or acknowledging pain is a big gap also in the way healthcare is provided, in recognizing it, acknowledging it. And I'm not talking only about physical pain, but also, no, we talked about the psychological and all the different scars that remain there. And besides pain, person-centered approach principles. There's many nuances and aspects around that. They should be part of any training to the healthcare workers or people who support, assist people surviving burns. And to finish, yes, measuring functioning as an health outcome should become part of the routine. It's still not part of the measurements of so outcomes like functioning, quality of life beyond survival, no? As we said, it was in the title of this session.
Thank you so much, all of you. I think we addressed all the questions. As I said, there was a question that's a bit technical around what to do that I will let you respond in the Q&A. But thank you so much. I think it was a very informative session and very insightful. Where, Judith, thank you so much for your testimony because it really illustrated everything that we've been talking about. So thank you very, very much to all of you for this session. And I will hand back to Dr. Dennis. Over to you, Dennis.
Thank you very much. Can you all hear me?
Yes.
Yeah. Thank you so much, Binta. And thank you, colleagues, speakers, partners, and participants. So as we come to the end of today's session, I really want to thank our speakers for the powerful words that they shared with us. And I'm just going to put up my screen. And the important discussion that we had. The conversation has reminded us of something that's really fundamental, that survival is not the end point of burn care. For too many children and families across Africa, surviving a burn injury marks actually the beginning of quite a long journey, one that may involve pain, disability, emotional trauma, interrupted education, financial hardship, and challenges returning back to daily life for themselves and for their family. We've heard today that rehabilitation, psychosocial support, and survivor-centered care are not optional add-ins to burn services. They're actually essential components of quality health systems overall. We've explored practical solutions, integrating rehabilitation care earlier in the continuum of care, strengthening referral pathways, building multidisciplinary teams, investing in workforce development, supporting caregivers, and ensuring that children and survivors remain at the center of how services are designed and delivered. So I just wanted to let you know that our next and last session will be happening next month, and there's a QR code here for all of those who would like to register anew for this session. But if you have already registered for our previous sessions, you should already have this link in your calendar. And then thanking everyone who has joined this webinar. Please take some time to fill out this evaluation form just to let us know how we can do better next time. We want to make this a continuous conversation that's happening between us and you. So we'll be sending you, for example, some of the resources we spoke about, and we'll be getting in touch to see if there are any other things that we can do together, the panelists as well as the participants, to make some of the things that we spoke about a reality and to help children who survive burn injuries to get back to society and become healthy, happy adults. So thank you very much to everyone. Thank you to the panel, everyone who spoke, and have a lovely day.
Thank you.
Thank you very much. Bye-bye.